Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
And today we have a special guest joining us, also from your neck of the woods, James. Your colleague, Clare Turnbull, is joining us. Clare, thank you for joining Melanoma Matters.
Well, thank you for inviting me.
Yeah.
So, well, I think as James knows, we like to start out with a bit of background and maybe follow your trajectory to modern day. So what can you share with us about your training, education, where you grew up and how you landed where you are now?
For sure, yes. So I actually start off at university reading maths. At school, maths was easy and it all made sense. And I got to university, it was absolutely terrifying. And I lasted 3 weeks and it didn't get any less terrifying. So I swapped and for the rest of the year studied natural sciences, which contained a lot of biology and human sciences. And the part I found most interesting was the human sciences. So I persuaded them to let me switch to medicine. So I then studied medicine and met Professor Larkin in my clinical studies. He was the year ahead of me, trailblazing with his wisdom and emerging clinical skills. And then after that, as is typical, did surgery, medicine, lots of junior doctor jobs, and eventually went into clinical genetics, having done quite a bit. Clinical genetics is a sort of cradle to grave specialty, or in fact pre-cradle. You see pregnant women right the way through to people with neurodegenerative diseases. So I did lots of jobs, including oncology, pediatrics, and so forth. Went into clinical genetics, went into research, and particularly cancer genetics spans very rare syndromes of the type clinical geneticists are used to seeing, but right the way through to thinking about common variant susceptibility in genes and environment, because so many cancers are actually very common. So I did a PhD, got a research fellowship, and then moved over into Genomics England, which was set up in 2012. I joined in 2014, so still relatively early. And Genomics England was a big government-funded initiative as a legacy of the Olympics, with the UK keen to position itself as a lead investigator and implementer of whole genome sequencing in clinical care. So I was very involved in the early days of setting that up and developing and delivering the cancer programme in particular. I then, in 2019, moved back to a full-time academic job. So I now work at the Institute of Cancer Research in London, so the partner organisation to the Marsden, where James is predominantly based. And I work in research into genetic susceptibility to cancer. And I see patients in clinic at the Marsden as well. So patients where the personal family history looks to have a heritable basis. So, and my team's called the Translational Genetics team. So a lot of what I'm trying to do is think about finding things in the research space, but more importantly, how do we bring them over into clinical practice? How do we make sure they're useful and impactful? And if so, how do we deliver them in a way that's feasible and scalable, particularly in a system such as the NHS?
Right, Claire, thanks. I've got some more questions to ask you about your background, if I may. So haven't you got a qualification in public health as well?
Yeah, so I did deviate when I was an SHO, which is one of the junior doctor grades, which actually no longer exists. So I went off for a year and did a master's in epidemiology and public health at the London School of Hygiene, which was a really fantastic break from clinical training. So thinking about how do you design and evaluate research studies, both observational studies and clinical trials, but also thinking about how you analyse the public health impact of our clinical practice.
Yeah, and the other two things I was going to ask about, the transition academia government body back to academia. Maybe not that common in this country, or maybe you'll say otherwise. Interested in the motivation. And then the other question is about COVID, because it'd be great to hear a little bit about what happened to you, I suppose, and what you did during COVID. I think it's worth talking about.
So I think there aren't really many government bodies that maybe you'd move into directly from academia, and certainly move back and forth between. I think Genomics England and the 100,000 Genomes project was very unusual, and it was really set up. It was very sort of time specific of an era as the genetic technologies were emerging and becoming affordable. And this enthusiasm from government, particularly David Cameron, and he had had a child who died from a rare heritable disease. So I think he was particularly motivated to support development and delivery of genomics. And they did just need some reasonably experienced clinical hands with the academic background, I think, as well, in order to design and think about how you develop the pathways for getting the tissue, doing the testing, returning the results, and so forth, but also how do you amalgamate the data that's been assembled in such a way that it's useful for the research community to work on it. So I was there for about 5 years, which is a good period of time, but after which I felt ready to sort of step back aside and have a bit more sort of authority and agency to determine which questions I studied and what I looked at. And then in terms of COVID, so I was sort of feeling a bit helpless and useless in my genetic epidemiological studies and research. So I sort of volunteered my hands to come along to the Marsden and be useful. And I think I was your SHO for a few days, but I wasn't very good at that. So I went off to do some other things, including working with the medical directorate to be a spare pair of hands and pull together flowcharts and policies. And as you probably remember, just policies were changing every week. What do we do with pregnant members of staff? What do we do for staff members who maintain PCR positivity and so forth? So we had to keep developing these policies and draw beautifully coloured flowcharts each time that the data emerged. And then I sort of started thinking about questions about prioritization, because we only had limited surgical capacity and we had to think about who we prioritized for surgery. And then it got into these questions of what are the sort of trade-offs. So we did start, and you kindly contributed, as did a number of subject experts in different areas of oncology, of thinking about that trade-off of, if you only have limited surgical opportunities, who should you operate on in terms of their risks of developing and dying from COVID and their benefit of gaining life years in terms of survival from their surgery. Which started off as a sort of Excel spreadsheet with which to argue with the surgeons who still wanted to do their Whipple's procedures and massive head and neck resections. But also then what we realised was actually it wasn't just the surgical capacity that was limited, it was actually upstream of that. It was all of the investigations and the cancer diagnostics. So we then started doing a piece of work trying to make the case, which in retrospect is entirely obvious and has been proven, that if you shut down cancer services, that you will just create this sort of bulge of mortality that will manifest 2 or 3 years later, which is exactly what happened. So we sort of showed with the 2-week wait pathway about the impact of different amounts of delay, 1 month, 2 months, 3, 6 months, and what the predicted impact would be in terms of mortality. And the problem is the world is not a randomized controlled trial, but it's certainly been observed that there has been a bulge subsequent to COVID of patients presenting late with the commensurately higher levels of treatment required and poorer outcomes. So that was sort of what I was sitting there. Having failed to be a very useful SHO for Professor Larkin, I moved my attention to during COVID.
I think he's probably quite demanding. I think I understand why it's difficult to succeed. Only teasing. Do you think we're past this wave, the bulge of cancer sort of surging and late phase? Are we normalized cancer treatment now and time to getting in, that we're past it, or we're still going to see it for some years?
essentially predict there'll be a long tail, but patients don't come with a sort of message on their forehead as to why their presentation was delayed. And then you also obviously have temporal changes that also affect cancer outcomes. So you only have sort of one stream of real-time data, and there'll be a number of contributory factors why outcomes are different in 2024 versus 2019 versus 2029. So you could we certainly saw that bulge, but it's quite difficult to get any precise data of what component of it is attributable to COVID, because there are other things, for example, changes in diagnostics, changes in pathways, changes in treatment, which have also changed concurrently as opposed to 5 or 10 years ago.
Yeah, I mean, Claire, that was a ridiculously modest answer by you, as usual. You know, actually, I think, you know, what you did during COVID was incredible. You make it sound like it was sort of, you know, all practical stuff, but you actually published a load of really important work during that time as well, without wishing to embarrass you so much. And, you know, that whole can do thing as well. You know, okay, here's the problem, let's get on with it. So not only understand it, but actually have some practical solutions. So, you know, that was amazing to see. So listen, this is Melanoma Podcast, and probably no one's listening to it or watching it. But if they were, and they're interested in melanoma, and you're a clinical geneticist, what would you think would be the sort of few top lines for people going into clinic and then they're seeing people with melanoma to bear in mind in terms of background genetic risk?
So melanoma, stating the obvious, is largely an environmental cancer. You would see a different incidence of melanoma if everyone sort of stayed in a darkened room 24/7 worldwide. In the same way, you'd see a very different incidence of lung cancer if no one smoked or had ever smoked. So if you were drawing a pie chart, the proportion of melanoma that's heritable is relatively small. As for most other cancers, by studying families in which there are multiple cases of melanoma, we've been able to find a few genes that are associated with melanoma. So in particular, genes like POT1 and BAP1, which is particularly associated with uveal melanoma. There's other genes where we've started off by studying the gene and looking at the family, so other genes that are characterized particularly around breast and or ovarian cancer. So BRCA2, PALB2, those were initially linked to melanoma, but the more recent data have suggested that that association is certainly less strong than originally published. So it is useful if you have a particularly young onset case of melanoma or individuals with a strong family history to make sure they're referred for genetic assessment, and testing for these genes can be performed. But actually the pickup rate's pretty low, even sort of POT1, even in those large multi-case pedigrees, the pickup rates in those early studies was it was a handful. I think it was 5 families out of 100. So you do find the pathogenic variants, the mutations, but they're not particularly common. And actually, as they've done larger studies, so getting away from looking in those clusters and just looking at the frequency of POT1 mutations in all comers with melanoma, they've been able to get a better, sort of more accurate handle. And it's only about 0.5% of all comers with melanoma have a POT1 pathogenic variant, but actually it was about 0.25% of the population. So that suggests the effect size is actually only about a 2-fold elevation in risk. So it certainly is associated. It will be contributing to the causality, but it's not having a POT1 mutation is in no means in any way makes it sort of guaranteed or highly likely that the carrier will develop melanoma.
You know, I don't know if that much has sort of changed in general medicine now from when we were junior doctors, but you know, the one thing, and this is boring, but important, that's really changed is strokes. Okay, so when we were junior doctors, right, a lot of the patients, you know, they just sort of, they drew the curtains and things like that. I don't think in terms of thrombolysis or anything like that, that's changed. But because that stuff has now been properly, right? And I don't know about mortality data or anything like that, but I cannot believe that it hasn't made a massive difference
Yeah.
to ischemic stroke. So that's, I don't know, it's important stuff. The question is obviously whether there's the will and, to do something about it, because it ain't sexy, clearly.
And it would just be marginal gains. But basically, if you didn't have symptoms last month and you do have symptoms this month, something's changed, something's growing, something's pressing on something. And that means this is a tumour that is sort of on the move. And that's when each week you don't chop that out and put it in a bucket, tips your likelihood into that becoming metastatic. And that's much more impactful to shave off those weeks there. And it's just actually quite kind of sobering looking at all those. They published a meta-analysis of all-cause mortality from sort of large numbers of screening studies for lung in smokers, prostate, colorectal, breast. It's the only one that shows any sniff of improvement in all-cause mortality is sigmoidoscopy for colorectal cancer, which they had to abandon because of lack of capacity.
If you don't mind, I mean, we're probably close to being done.
All right. We are doing a fact check now for the episode with Clare Turnbull. I was about to give it an episode number, but I'm not convinced I know which number this is going to be, so we'll just not do that.
Maybe 62 or not?
63.
Okay, that could have been premature.
Yeah, I think we just did 62, which was the post PD1.
Oh yeah, so it'll be 63, right? Sorry.
Okay. We're doing, if I can get around to finishing these in order. And we're splitting her episode into two, as we said, because it was just so full of good listens. And each episode won't be equal in length, but I think it's just going to be worth listening to a few times because she says such good things about the power of screening and the dangers of over-testing, over-diagnosis, lead time bias, which then I gave her an example for uveal melanoma because it comes up often. Are we really doing benefit when we just increase this lead time of knowing somebody has their cancer? Oops, sorry, I'm getting a bunch of texts. So we're splitting it into two, and we were just going to do fact check for this first half of the episode. So the first half, we really started off talking about her background and things. And anyway, maybe you can take us through the beginning parts of the episode and some of the facts there.
Yeah. So actually, I was just thinking since we talked, but Claire and I used to know each other as undergraduates in Cambridge. And I only found out last week or the week before from another friend and colleague, Nick Turner, who's a breast cancer medical oncologist at the Marsden. Hi, Nick. That actually Claire and Nick had started off doing natural sciences at Cambridge, which is something people kind of used to do, and then transferred into medicine. And, usually that would be after a couple of 3 years. So the serious point I was going to make there was that it's great, actually, that both Claire and Nick did do that transfer, because had they not, then maybe they wouldn't be doctors and we wouldn't be working with them today. So Nick told me last week that he and Claire were the last two people ever to do that at Cambridge University. So this would have been in the sort of early 90s. So that's quite a nice little footnote. Go on.
She mentions it on the episode. She talks about how she starts off in maths, and then you bring up, who else were some pretty maths geeks that you bring up? Yeah. And then she talks about A Beautiful Mind. She's like, it's like a scene out of A Beautiful Mind where they're just writing stuff on the board, and she says it's 9:03 and I'm already fully lost. So then she does the transfer into medicine, much to our benefit.
Yeah, and people used to complain actually that it was a kind of quote unquote backdoor into getting into medicine. But I think if you look at Claire and you look at Nick as well, I mean, these are people of the very highest caliber. So that was a unfair characterization.
Good choices in backdoor, if you will. Good backdoor.
Yeah, well, obviously important and critical even. So just to fact check, we were talking about David Cameron, Conservative politician. Now Lord Cameron of Chipping Norton, just looking at his Wikipedia page now, leader of the Conservative Party and Prime Minister and I'm just trying to get the dates right, basically May 2010 till July 2016. So he resigned actually right after the Brexit vote. In fact, I think maybe the following day or a day or two later. So you and I have talked about Brexit a little bit, but there's your date of Brexit, which was, or the vote anyway, July 16. The actual kind of leaving the EU took several years afterwards, and we're still dealing with the consequences now. And so then the next bit, I think Claire makes some comment about being my SHO, senior house officer, which is slightly ridiculous, and Claire being very modest as always. But what actually happened, and this is February, March, April 2020, now 5 years ago, when
well past the time that she would have been an SHO training.
Yeah, Claire was a consultant geneticist and had a group at the ICR, ran a research group, and had been working at Genomics England in a senior role. So Claire jokingly said she'd been my SHO, but this was when COVID really hit, certainly in London, which was the first place it hit. And in fact, what happened is a load of people had been on skiing holidays to the Alps at the end of February. And of course, in Italy in particular, COVID was maybe a few weeks or a month in advance of where it was. And so a load of people, end of February half term, go skiing, come back with COVID. And some of my colleagues and friends I know this happened to. So when it really started moving quickly in London was in the weeks following that, March, April. And when it became clear that honestly we were potentially even at risk of getting overwhelmed, Claire volunteered her services to be a general medical SHO looking after patients on the ward. So when she said that, what she actually meant was that she said, well, hang on a second, I'm not sure there's going to be a big need for genetics clinics in the next few weeks. What can I do to help looking after patients? And she just went in and she was a doctor on the ward. So,
well, because the way she tells that story, it just sounds like, oh, she was below you in training, and then she was it didn't really, I mean, the humility with which obviously she was saying that, to hear you now say she just really took stock of the situation and came and threw herself in.
Yeah, that's exactly what happened. What can I do to help? Roll up my sleeves. And she was, one of many people who at the time sort of, dropped their day job, as it were, or kept it going in parallel and actually went and looked after patients directly on the wards, many of whom honestly had severe COVID and some of whom died of COVID, unfortunately. The other thing, just to be really...
A pause. So during this time, we were on an IDMC, and then we would periodically meet, every 3 or 4 months and whatever. And it was clear you guys were getting hit hard. I mean, you made some offhand comments to the other IDMC members about COVID and, surviving it or whatever. But now in hindsight, I can understand how you were running this, skin unit. What are you, head of skin there? And on top of COVID coming crashing down, on top of, having to sort through people who are just coming to offer help, and then not to mention family stuff and whatever. It just makes me realize, like, gosh, what a time we all lived through.
Yeah, exactly. Yeah. Anyway, and it'll happen again. Let's put a marker down there. No, it will. It's just a question of when the next pandemic is. I mean, I don't want to go on at length about that, but that's the question, and what it looks like, unfortunately. Anyway, and so then the other thing that Claire did, in addition to doing frontline clinical work, was to actually think, well, how could she help from an academic perspective with all of her skills? And I know that she did loads of work with our surgical colleagues in terms of prioritization of surgery, making things work making things work effectively given all the pressures. And at the same time, as ever with Claire, was exceptionally academically productive. And just to pull out a few papers for those that are interested, there's a paper in Gut in 2021, first author Loveday, Claire's the senior author, about colorectal cancer referral pathways. So this was a big issue during COVID, delays in diagnosis and referral. There's an editorial in Lancet Gastroenterology and Hepatology, also early 21, which Claire wrote, She was the only author there. And some of the stuff that we did together, there's just a paper I'm looking at, Lancet Oncology, August 2020. Amit Sood, who's a hematologist, actually is the lead author on that one. Myself and a few other people like Charlie Swanton, who you'll know, contributed to that. And again, Claire was the senior author on that. And that was about the effect of delays in, we have this 2-week cancer referral pathway in this country during the COVID-19 pandemic on cancer survival in the UK, and it was a modelling study. So some of that is about, if you stop doing the kind of routine work that we're meant to be doing as oncologists, there's going to be a consequence down the line. And so then you have to actually think about how you prioritise these different competing things. So Claire made an amazing contribution, as many people did.
I asked her on the episode, I said, do you think we've recovered from that, what was a 2-week delay, but, that delay was 1 month, 2 months. I think it's in that modeling study. And I said, do you think we've recovered from those delays? And she said, oh, no, this is going to take years to bear out, to really right side up what we did as a reactionary, event to this. So, yeah.
Yeah, I mean, and just I'll make another little political point there as well, is that some of the issues with kind of lack of trust in what the government did at the time, they take even longer to recover. If people become suspicious of what the government's doing, or they don't trust the government, or there's inconsistent messaging, the public are told to do one thing, politicians are doing different things in private, that kind of loss of trust takes years and years and years to recover, if it ever does.
Well, one of the things I guess now we were remiss in probably asking, as you link those together, I wonder what the linkage is between that public loss of trust in how things were implemented, and then subsequent vaccination uptake or lack thereof, how those all have linked together and how they'll stack together in this cancer population in particular.
Yeah, so that's an excellent question. I'm not aware of any literature on that, but I'd love to see some. It's a kind of multifaceted issue there, and there's just so many kind of cultural, geographical, and other sort of variables in there. But it's a really important question. But we might need to park that for episode 563.
Oh, good job.
If we're still going.
Good forecasting there. It's only like 2.5 years away. So I just want to close on one thing that she said that I thought was really charming. She said in the episode, the world is not a randomized trial. And I think that was in reference to some of the data that was coming out of COVID. I just thought that was a nice kind of soundbite there. So thanks for this little bit. And if you thought this episode was interesting, I think part 2 will be just as fascinating as we talk about surveillance and screening, and things. So,
Great.
All right, thanks.
Thank you.